It's a kind of a review of where something called radiotherapy dose painting is up to, or at least that's the first 3/4 of it. And then I've added some material to the end because it's kind of tangentially related on correlations between PET imaging and genomics. You should find the dose painting description is quite thorough and it's quite a decent review of where the field's up to. You might not find it that scientifically inspirational. The genomics correlation stuff is perhaps more interesting. Anyway, that's where we're going. So here we go. Right, now, dose painting was an idea that was proposed back in, say, 1998 by a guy called Cliff Ling, who worked at Memorial in New York. And he suggested at a conference in Edinburgh that I was at, and then he published the idea in about 2000. And basically didn't really go anywhere until at least 2005 because radiotherapy was very busy implementing and developing IMRT at the time. Anyhow, what he said in Edinburgh, which came as a shock to most people there, was that intensity modulated radiotherapy might have started the beginning of the end of the process of physical conformality in radiotherapy, and which came as news to everybody who still thought it was the future. And that biological imaging might launch the start of a new era of biological conformality. And what he was really getting at is that even on CT images, you can see that tumors aren't uniform, and that's even more the case on all sorts of functional images. And yet, kind of since the dawn of time, radiotherapy has attempted to deliver uniform doses right across planning target volumes. And so that raises the whole question of whether you should be doing that, whether you should be varying the dose, whether you should be identifying biologically driven target volumes rather than stuff on CT images, and so on. So the major part of this talk is just looking at the progress on that idea and how it's gone forward over the last 20 years. I want to start off by getting some obvious points just ticked off. So first of all, of course, over the last 20 years, PET images of FDG PET has become increasingly used for tumor staging and for tumor delineation. Everybody knows that. But the real question is, how are the techniques that try to vary dose across the target volumes working out? So there's been quite a lot of work done, say, since about 2005. An awful lot of it working through the images that you get. So people have looked at associations between functional images and histopathology to check that the images mean what you think they mean. They've looked for associations with survival, because if the images aren't in some way linked to survival, it seems questionable as to how far you'll get modifying dose on the basis of them. And they've also looked at image stability as well, because you need the thing, whatever region you're going to hit, you need it to be fairly stable. In addition to that, there have been loads of studies looking at how dosimetrically feasible it is to boost small tumor subvolumes while continuing to meet all the regular normal tissue dose limits. And there have been quite a few now phase 1/2 trials that have reported results, and we are still on the cusp of getting results from phase 3 studies. You might say that that's 20 years after the idea was advanced, which seems quite a long time. But if you look at intensity modulated radiotherapy, that was suggested in about 85, and we had to wait until the late 2000s for phase 3 results from that. So it's a similar sort of a time scale. Okay, so there's been a lot of work looking at what you might view as the prerequisites that have to hold if dose painting is actually going to work. So the first thing that people have checked through is that functional images are actually correlated with the relevant aspects of tumor function. So for example, there are lots of studies looking at links between FDG PET images and F-MISO PET images, uptake in them, and checking whether it's correlated with hypoxia markers. And that can either be electrode measurements of hypoxia or pyrimidazole staining. And there have been similar studies done for FLT, which is supposed to be a tracer of proliferation, checking it against Ki-67, which is an endogenous proliferation marker. And there have been analogous results done for MRI in prostate radiotherapy as well, checking that multiparametric MR is a marker of intraprostatic cancer lesions. So that, by and large, is worked through. There's a second prerequisite that's been checked through, that the baseline images, the pre-radiotherapy images, have some sort of relationship with outcome. So for lung cancer, people have found out that high FDG uptake in the baseline scans is correlated with high levels of residual uptake after treatment, and that those in turn knock on to associated poorer survival. For head and neck cancer, similarly, recurrence after radiotherapy was found more likely to originate from high FDG uptake regions in baseline scans. So those are links between the images and kind of survival. And then the third prerequisite that's been checked is that the high uptake regions are relatively spatially stable. So for lung cancer, that's been tested over 1 to 2 week intervals. For head and neck cancer, it's been tested over 3-day intervals. The finding is generally that they're relatively stable. So that's quite good news, because you need all that to hold for dose painting to work. It means that you've got high uptake regions that mean something, that are related to survival, and that are stable enough to target. But on its own, that's not going to be enough for it to work. So there's been a lot of other work put in as well. So other stuff that you need, and these points sound surprisingly obvious, but what I'm going to do is to work through them specifically for lung, head and neck, and prostate, and you'll see that various of them fall down at different points. So the other things that you need to make this idea work is, first of all, unsurprisingly, there has to be a dose response when you uniformly irradiate tumors. In other words, if the survival doesn't improve as you increase the uniform dose, it seems very unlikely to improve if you increase the dose to a boost volume. Secondly, there has to be enough headroom. You have to actually have the scope available to increase doses to the tumor subvolumes a reasonable amount without exceeding the normal tissue dose limits. And thirdly, and importantly, obviously, the dose response that you see for uniform irradiation, if it's there, has to persist when you only boost a subvolume rather than the whole tumor. So I'm going to check through those points for these different tumor sites. So starting with the question of dose response, looking at lung cancer, there have now been lots of analyses of published data that indicates increases in survival with dose for radiotherapy alone or sequential chemoradiotherapy. The situation is far more ambivalent for concurrent chemoradiotherapy. So there's quite a lot of work being done there to tease out effects that are potentially due to cardiac toxicity at high doses. But the long and short of it is that there's reasonable evidence for a dose response. For head and neck cancer, similarly, there's pretty good evidence for a dose response as you increase dose by 10 Gray. For prostate, interestingly, there's decent enough evidence for improved biological progression-free survival if you increase the dose by 10 Gray. Very much less indication that actually leads to an improvement in overall survival. I'll come back to that point in a bit. So that's whether there are dose responses or not. And the answer is yes for head and neck, yes for lung, perhaps for prostate, but perhaps not. In terms of the headroom that's available for escalation, my old group did a study of this about 7 years ago when they were down in Oxford, and they just took sub 10, I think, stage 2-3 lung cancer patients. The target volume was the tumor and the lymph nodes that were summed over all the phases of 4D CT with a standard margin applied. They defined some fairly standard normal tissue avoidance regions, which are called PRVs. That was the mediastinal envelope, which is basically a sort of central region that includes airways and large blood vessels and stuff, and the esophagus and the spinal cord. All of those patients had some overlap between the planning target volume and the avoidance regions. That's due to movement margins. And so then we performed a planning study. I won't go into the technicalities of it, but the idea was that we tried boosting either the part of the tumor that lay outside of these critical avoidance regions, or the part of the tumor that lit up on PET scans that lay outside the critical avoidance regions. So that's obviously a sort of a smaller region. You can see that bottom left. What we found was that either way, in fact, the scope for dose boosting was really quite limited. If you targeted the entire volume lying outside the critical structures, you could get about an extra 7 Gray in before you started exceeding other dose limits. If you just restricted yourself to targeting the high FDG uptake volume, you really couldn't get any more dose in. It was about 6 to 7 gray as well. And in fact, it was just disadvantageous there because you were obviously missing out on irradiating the rest of the tumor that lay outside the avoidance region. So that indicates that you might have some issues with lung cancer, because if you increase the dose to the whole tumor by 6-7 gray, you might expect an increase of about 5% in 2-year survival, but it's going to be less probably if you only boost a subvolume anyhow. There's been a phase 2 study done for lung cancer. That's the PET-BOOST study, which is a European study led from Mastro. Now, it's quite an interesting study because it did 2 things. Firstly, it explored a considerably wider range of dose boost to these high FDG uptake volumes. And secondly, it did something that's quite standard in certain types of radiotherapy lung treatments, which is they were trying to keep the mean lung dose the same. So the same for all patients. The reason for that is that historically pneumonitis is a key toxicity of lung cancer, and pneumonitis is very linked to the mean dose that you deliver to the lung. So in this study, they were trying to keep the mean lung dose the same, and obviously the mean lung dose is quite heavily linked to the mean tumor dose. So what they did was if they boosted the dose to part of the tumor, they kind of deboosted the dose to the rest of it to make up for it, so that the total dose the tumor got was the same, or the average dose was the same. There were a few other things they did. They set an unspectacular mediastinal envelope dose limit. The interesting thing was that they delivered a median average PTV dose of 76 gray, which is high-ish, but not spectacular. Some of their doses went right up to 119 gray, which is quite high. The advantage of that was that it meant they were able to very clearly test the dose painting hypothesis. That perhaps a disadvantage is that they got quite a number of high-grade adverse events in the study. They actually presented some initial survival results at ESTRO 2020, and the survival is not particularly different to standard survival. So that was that's the first kind of definitive or semi-definitive results for lung cancer, and it was kind of what might have been expected, I think. For head and neck cancer, there's more headroom. So there have been phase 1 studies carried out in Ghent. These are actual trials, not planning studies, that found that 85 gray EQD2, so 25 gray and 2 gray fractions, was tolerable to a tumor subvolume. There's a phase 2 study in Heidelberg that found that 78 gray was tolerable. Those are both about, let's say, 10 gray up on standard kind of doses. And as I was saying, you'd expect about a 15% local control gain for a 10 gray increase if you gave it uniformly to the whole tumor, but it will be less presumably if you're only boosting a subvolume. But nonetheless, that seems like it's in a kind of a useful sort of area. There turns out to be more headroom yet for prostate. So there's a phase 2 trial, Delineate, which has reported, that's a British one, that's reported that 90 gray subvolume doses are tolerated when they're given using external beam. Interestingly, there are other studies that show that if you use brachytherapy, so that's where you implant a source, or at least you use a catheter to drive the source into the prostate and then remove it again, then the subvolumes can tolerate up to 140 gray. Now, because there is not yet much evidence for an improvement in overall survival for external beam radiotherapy when you just increase the dose by 10 gray, looks to me as though the brachytherapy boosting approach is an interesting one, because you can get such a higher degree of dose boosting. Okay, and then there's been some really interesting work, some really interesting preclinical work done. So if you're going to test dose painting, you can obviously test it a lot more rigorously in small animals than you can in people, because you can try very different patterns of dose distribution to the tumors. So in this particular study, which is another one from Maastricht, what the investigators did, they were investigating rhabdomyosarcomas, and they gave either 8 or 12 gray mean doses to the tumors. And what they would do is to either treat them uniformly, or they would boost the hottest 30% of the volume in FDG scans, and they boost that by either 40 or 60% relative to the rest. And the key thing here is that they were even when they were going for this dose boosting, they were still maintaining the same mean dose. So it would either be 8 or 12 gray mean dose, which meant they were having to deboost the rest of the tumor to make up for that. And what they found out was that at 12 gray mean dose, the mean time for the tumor volume to double after radiotherapy was 20 days, and that was regardless of whether they gave the irradiation uniformly across the tumor or whether they boosted the high FDG uptake volume by 40% and deboosted the rest. 8 gray was actually, that's no effect, if you like, for dose painting. 8 gray was worse. Turned out that the mean doubling time actually went down when you dose boosted. So it went down for a 40% dose boost, and then it went down more for a 60% dose boost. Obviously, they were using these mean doubling times as a kind of a surrogate of tumor response. So to just summarize that then, the preclinical data showed either unimproved or worse tumor response for dose boosting when they were holding the mean tumor doses at a fixed level. And obviously that required lowering the doses to the unboosted areas to compensate for the boosting. And the reason that they did that goes back to this point I was making about the lung radiotherapy study, because if you want to deliver a fixed mean lung dose, which is a common aim, that's probably what you would end up doing with the tumor. However, in head and neck, the tumor doses are often limited instead by the maximum doses that are received by nearby normal tissues. The same is true for prostate. And it's perfectly possible to boost doses in the tumor interior and just leave the tumor edge doses the same and thereby meet the maximum normal tissue dose limits. In other words, you don't need for those tumor sites to kind of de-escalate the dose to part of the tumor. And that approach potentially can produce a gain, particularly, and I'll discuss this in a couple of slides' time, particularly if the boost doses are carefully guided by the functional images. Okay, it's actually this slide. So in terms of how you might get from, let's say, a PET image, could be an MR image, to a dose boost in terms of how much you might want to boost the dose, there have been two approaches that have been suggested and tried. The earlier one is called dose painting by contours, and basically what it does is to pick up some particular level of PET SUV, say. I'll come back to that idea in a minute, that's supposed to be greater than some cutoff that's associated with the site of recurrence or something. So you say, all right, 40 to 50% of the SUV max is a problematic sort of a uptake on a functional scan. And then you go targeting that with a boost dose. So that's represented, if you like, by the red line on the plot at the bottom of the screen. The alternative approach, dose painting by numbers, tries boosting according to kind of progressively rising dose prescription curves. So they start off at the baseline dose, and then for higher and higher SUVs, the dose gets kind of progressively higher. And people are doing work right at the present, trying to figure out what the shape of those curves should be. And there's quite nice work going on trying to estimate them from links between the doses delivered to particular points, the SUVs at them, and whether or not they're kind of sites of recurrence. Another aspect, so I'll come back to SUVs in a minute because there's more to be said about that, but another aspect of dose painting that's being worked on at the present is margins. So I was saying earlier, in radiotherapy, it's standard to add a margin around a tumor and to treat the margin to a high dose. And the reason that you do that is partly to cover microscopic spread, but is also partly to cover tumor movement. Obviously, the issue for dose painting by numbers is that there is no clear-cut boost volume because you're potentially varying the dose smoothly right across the tumor. For dose painting by contours, there is a clear-cut boost volume, so you could apply the same type of approach. These approaches, the margins that are set are, in theory, probabilistic. So the idea is people have measured how much the tumor moves, and from that they've worked out how big a margin you need to be able to cover the tumor most of the time. The problem is, imagine a typical margin size might be 7 mm. So imagine you apply that to a 6 cm tumor. What you actually do is to expand the high dose volume as a result by about 88%. Now, if you apply the same margin to a 2 cm tumor subvolume instead, you increase its size by 390%. So in other words, the sort of higher resolution of the dose painting approaches means that it stresses the margining approach. It kind of worsens the resolution, I guess, and it means that really you need a more high-spec approach to dealing with movement if you're going to do kind of high-res dose painting, which is a nice area, presumably at some point in the future, for MRI LINACs, which are becoming available and allow you to turn the beam on and off when the tumors and the subvolumes and everything are in the right place. Now, I just want to head back to SUVs, and I want to ask the question of whether there might be more to PET images than SUV. Just as a bit of background, an SUV is a standardized uptake value. What you ordinarily do when you image a patient using PET is to inject them with a radiotracer like FDG, wait an hour, put them on a scanner and image them. And then the SUV is the uptake per voxel relative to the average uptake per voxel in the patient, essentially. So if the tumor has an SUV of 2 on average, that just means that it's got twice as much tracer in it as the rest of the person on average. Now, there's an important issue when you're trying to figure out what the SUV means in terms of dose painting, which is this. Imagine that you get an image and imagine the SUV in a particular region has increased by, say, 1.3. Does that actually mean, is that telling you that the cells in that region are more radioresistant than other cells? Or is it just telling you that there are more cells that happen to be radioresistant? Now, that sounds like a sort of an issue of semantics, but it really isn't. Because obviously, if the radioresistance per cell is increased by a factor of 1.3, you're going to try to correct that by increasing the dose by 30%. On the other hand, there are quite a lot of models of how tumor control depends on dose and numbers of cells. Nobody really knows whether those models are true or not, but they're very widely used. And if you felt that all that had happened was that the cell density had increased by a factor of 30%, because of the exponential nature of cell killing, you actually would need a far smaller increase in dose to be able to counter that. You'd only need to sort of whack up the dose by about a couple of percent. So it's interesting because the interpretation of the image quite drastically changes the degree of dose painting that you need, and that's an unresolved issue at present. More finely, perhaps, there are interesting questions about whether this late uptake is telling you as much about what the tumor is doing as you think. So there's a whole area of dynamic PET, which aims to achieve more accurate quantification of tumor function. The idea there is that you inject the patient, and then rather than waiting to start imaging, you start imaging immediately, and you collect a time course of sequences, and then you can generate curves from that of tracer uptake by the tumor and the concentration of a tracer in various blood volumes, like the heart, say, which represents the blood flow of the tracer into the tumor. And you can apply some kinetic models to all of that to kind of de-wind the input function from the tumor tracer uptake. And depending on what those models are, they spit out a load of parameter values, which may or may not tell you more about tumor function. So these are just the sort of compartment models that are used, and it's showing the sort of flow of the tracer from the blood through the tumor interstitium and into the cells. And you can have simpler models than this. You can have the PATLAC model, which is basically a one compartment model. You can have even more complex models, and so forth. So we've been doing quite a lot of work trying to test whether that's a useful approach or not. And we've been looking at dynamic versus static PET. That's down in Oxford, in a window of opportunity study of the effects of metformin on breast tumors. We fitted about, I think, 5 different kinetic models to the dynamic PET data, and we've carried out a gene set enrichment analysis to find the number of KEGG pathways that are significantly associated with all the different imaging parameters, including the conventional static measures like SUV and the tumor to blood ratio at a late time point. Each of these kinetic models, in addition to all the micro parameters, which are things like rate constants of flow of the tracer between one compartment and another, they're also associated with a flux constant. And a flux constant just tells you what the rate of tracer uptake in the tumor would be if the concentration in the blood was some steady unit level. And really what it is almost a late uptake value that's correctly normalized or corrected for patient-to-patient differences in the time course of the tracer flowing into the tumor. The most simple model that we tested was the PATLAC model, and the results we're getting are shown on this slide here. So on the left side, that's baseline data, that's pre-metformin data. All the different pathways that are correlated with stuff are shown down the y-axis, if you like. The different imaging parameters for different models are shown on the x-axis. All the lines, all the vertical lines that are lighting up, those are all flux constants, and all the rest of the stuff is the micro parameters that are far less associated with pathways, and that's probably largely because the statistical uncertainties on the micro parameters are quite a lot higher. It turns out for the baseline images that, shown in the left-hand slide here, that the PATLAC model is associated with more pathways than anything else, including SUV and TBR, but that's not a significant trend. It's interesting, though, that the simplest compartment model does the best. The situation in change data is shown on the right. So this is where we're looking at associations between changes in gene expression from before to after metformin versus changes in imaging. It's sort of the same pattern. There are less correlations, and that I think is partly because the change data is noisier, and it may also partly be because it's just reflecting specific changes kind of related to metformin, whereas in the baseline stuff, that's patient-to-patient variation in everything. Again, it's mostly the flux constants that are significantly associated. The interesting thing this time is that the static measures, so SUV and TBR, are not correlated with all that much, and also that the PATLAC model flux constant is associated with significantly more pathways than SUV or TBR, so it seems to offer some advantages. Now, more interestingly than that, you can look at the different pathways that are associated with those imaging parameters. And it turns out that so this is just a plot now of all the genes in the pathways, that those are being plotted on the y-axis versus the different pathways on the x-axis. And it turns out that 4 of the pathways have large numbers of genes in common. So those pathways are the oxidative phosphorylation pathway, and then pathways associated with Parkinson's, Alzheimer's, Huntington's disease. And the genes in common that they have are SIKE1 and series of ATP5, COX, NDUF, SDH, and UQCR genes. So the interesting thing is that all of those genes code for elements of the mitochondrial respiratory chain. And complex 1 of that chain is a known target for metformin. There are 2, metformin, I should give you a bit of background. Metformin is a diabetes drug, and there have been observational studies that have found out that the survival of patients taking metformin for diabetes who've got cancer is better than the survival of patients taking other drugs for metformin who've got cancer. So it's now being investigated as an experimental drug for cancer treatments. And there are 2 possible reasons people think why it might work. One is this particular targeting of the mitochondria, and the other is a more systemic effect due to the amount of gluconeogenesis, I think, in the liver. Anyway, one potential mechanism is this particular one, and it's interesting that all those genes light up, showing correlations between the imaging and the genomics. So then, this is almost the last slide on this. On the left-hand side is a heat map showing all the different genes in the oxidative phosphorylation pathway. So they're being plotted down the y-axis, and across the x-axis are all the different imaging parameters. It's a clustered map, and what you can see, there's a cluster that describes the results for the PATLAC and 2 simple 2-compartment flux constants. That's the green arrow. And then there's another cluster that shows the results for SUV and TBR. Those are the static measures, and fairly clearly the dynamic measures are better. The right-hand side plot is a similar one. This is a gene signature taken for mitochondria. It's mitochondrial genes that are known to be upregulated in breast cancers. So we looked at that as well, and you see the same sort of effect. This slide doesn't have a plot on it. I got the actual data for it about 10 minutes before the start of the talk, which is kind of annoying, but never mind. So the idea is that from those plots, you can calculate gene signature scores, and then you can see how they regress against the Patlak flux constant and the SUV mean. And clearly the regression is going to be tighter for the Patlak constant. So if you say, well, what does that mean in the specific instance of this study, it presumably means that the dynamic PET is a more sensitive kind of measure of treatment response than is the static PET. But if you extrapolate that back to dose painting, it may mean that there's a role for dynamic PET there. And there are groups, the Heidelberg group, which is looking at dose boosting on the basis of images of hypoxia, so that's F-MISO-PET, is using dynamic PET as the basis for their studies. All right, so I just want to wind up with a few summary points from all of that. The first is that there have been these large number of studies now that show that functional images are relatively stable and they're related to tumor biology and to treatment outcome. So that looks good for dose painting. It's clearly important it's critical really, to select tumor sites for which there is both the headroom available for dose boosting and also a demonstrable survival dose response when tumors are uniformly escalated, and head and neck cancer seems to be a pretty decent example of that. It's interesting there's an ongoing need to develop and test well-designed methods to account for tumor movement, and also the design and testing of dose prescription functions is really critical to give dose painting the best chance of working. The thing that interests me is that when intensity modulated radiotherapy was developed, of necessity, the physics came first, because you had to find ways of modulating the dose before you could test it, and then there was lots of clinical work. With dose painting, other than the original idea, which was suggested by a physicist, actually the lead has been mostly clinical, and these latter 2 points, the movement correction and the dose prescription functions, these are both kind of physics tasks, and they've only really started having a lot of work put into them within the last 3, 4, 5 years. So it's a strangely different way around. Okay, so that's it, and then those are just some acknowledgements of people who've worked on the metformin study and funders and so forth.
John, thanks so much for that. Really, really clear talk. Clarified a lot of issues for me. So going to the chat, no questions on at the minute, but everybody's welcome if they choose to type in a question. Whilst we're waiting, John, I've got one question for you, if I might. So you spoke throughout your talk about, particularly with the non-small cell lung carcinoma work, LaFontaine et al., whereby in an attempt to boost dose at high SUV points within the tumor, you actually necessarily reduce dose in other points of the tumor to keep the mean dosing uniform.
Yeah.
So, and you'll not be surprised why I'm asking you this, but in the context of tumors that are known to be highly radiosensitive, such as HPV positive tumors, for example, has anybody thought about the opposite approach to that, or the counterintuitive approach to that, about function sparing strategies whereby you might keep the overall maximum dose to any SUV hotspot in the tumor the same, but actually with the plan to enhance function, to reduce dose to the areas that respond?
Yeah, so that's an excellent question. And the short answer is that I'm not aware of any studies that have done that. If you say why, it's because the three areas that, yeah, it's because of my background, maybe the areas that I really know about lung and prostate, and both of those are, well, prostate there's been a large focus on dose escalation, whether or not it's worked and whether or not it's necessary. Lung, there's obviously a focus on escalation because the outcomes are not that great.
Yeah.
I am not, so far as I'm aware, all the head and neck work has been done on escalation rather than what you're effectively suggesting, selective de-escalation, which sounds shrewd to me. I'm not aware of people having tried it.
Okay, good. So question in from Jason Parsons, and Jason says, what about dose painting in the context of protons? Has that been investigated? Has it been thought about? Is there any, at least theoretical benefit that might come from that?
Right, so it's definitely been thought about, and it's even been investigated, because there is a lung dose painting trial in America that uses protons. So there have been 2 lung dose painting trials that I'm aware of. The one is the Mastro study that reported at ESTRO this year. So that's the European study. And the other one's this American study, which comes out of MD Anderson. And I think the short answer is that the word on the street is that the American study is going to get a negative result. But I wouldn't be too discouraged about that in terms of dose painting in general. That's because it's lung cancer, and there's just an awful lot of factors on lung cancer that we don't know about. The stuff to do with cardiac toxicity and how it affects survival and all sorts of things. So the answer is people are thinking of it and looking at it and so forth.
Okay. So another question for me, if I might. So in the context that you made some reasonable statements at the beginning to suggest that increased SUV, even throughout treatment or prior to treatment, was correlated with things that would suggest worse tumor outcomes. But the one thing that we didn't talk about, I think you touched on it a little bit when you were talking about time course studies, is that we're pretty aware, I think, that there's a chronology to that. SUV uptake obviously persists even after treatment, and we know that those could be sterile lesions. So what's the criticality of chronology in this? You know, timing around SUV response.
Right.
Where do you hit? And what's the data suggest on that?
Right. Yeah. So that's another really good question. The short answer is we don't have enough information. The reason that we don't is that, I mean, you'll be aware PET scanning is quite expensive. So the number of studies that have looked at scans at serial time points and then looked for associations with survival in decent numbers of patients is few and far between. And I think there's also a positive spin on it. So when people started getting answers, finding that, finding, as you say, reasonable answers that show some sort of link between FDG uptake and response, they kind of said, okay, that's fair enough motivation to go and set up some dose painting studies. As a physicist, I found that slightly frustrating because, to my mind, there's a huge amount of interesting work to do on tumor dynamics and looking at sequential images and seeing what happens over time and how it links to survival and everything else. And that there are a few studies like that, but they're the exception rather than the rule.
Thanks, John. A couple more questions in. So Francis Greeny Davies has asked a question which he thinks is naive, but I don't think is naive. Is if you dose paint a tumor, what about the context of repeat exposure in a recurrent setting? That dose tolerance, I suspect that hints at, is, do you have maximum? Does that make it worse? How does that work?
Right. Well, so I mean, the first answer is depends how you've done the dose painting. If you're imagine that you're giving the same integral dose to the tumor, the same average dose to the tumor. You probably have upped the maximum doses to some critical structures a bit, but no more than you would have done if you tried dose escalation uniformly. And you won't have increased the average dose to say the lung or whatever. And so you're probably in, well, you're not going to be in any worse position than if you tried escalation uniformly. And there are plenty of studies of uniform escalation. It does mean that if you have recurrence, it's more difficult. I mean, and that's a broader issue than just dose painting. For instance, with prostate radiotherapy, where the uniform prostate dose has been increased over the last 20 years from 64 to 74 Gray effectively, hasn't really produced an improvement in survival, and it makes it more difficult if there's a recurrence potentially. There's a question about whether dose painting might be used for radiotherapy treatments of recurrent tumors, which is an interesting one, because there you could follow exactly the approach that you've suggested, Terry, of trying to deliver a reasonable dose to the most problematic part of the tumor according to the images, and spare the other stuff, which might allow you to spare the normal tissues better.
Okay, thanks, John. Next question is from Claire Patterson. Claire, thanks for dialing in. It's good to hear from you. And Claire asks, well, first she says, thanks for a very interesting and clear talk. And then she asks whether you're aware of any dose painting studies for functional MRI. And
yeah,
contours and numbers, and specifically for head and neck cancer.
Okay, so I was about to say yes because there are lots for prostate, but then that turns into no because I'm not aware of any for head and neck cancer.
Okay, that's good. Talk to us a little bit about the prostate ones. How does it help add precision? What's the
right? So there have been lots of studies showing that the citrate choline ratio or whatever is, which you can measure using functional MR, is related to kind of prostate cancer, and so you can use functional MR images to identify subvolumes within the prostate. It's a little bit different, I think, to the sort of standard position for a tumor, in that obviously the prostate is a normal tissue that's become infiltrated by tumor, and so you have little nodules of tumor that you really want to kind of dose escalate to, and so there have been quite a lot of studies using functional MR. Isabel Syndicus at Clatterbridge, I think, started off using PET and then switched to MR. The Marsden has run its own dose painting trial, a slightly bigger trial, I think, for prostate, and that was based on functional MR, and that had a full workup of sort of excising prostates and checking them against the MR images and so on.
Okay, great. So next question, whilst we're down this end of the body, we have a colorectal cancer surgeon as an interloper, and you're very welcome, Dale. So has anyone tried dose painting in locally advanced rectal cancer?
Yeah, is the answer, and that's or no. So the guys in Oxford were very interested in that, and in particular they were interested in. So obviously, if you look at what you might want to boost, hypoxic subvolumes are of particular interest to radiotherapy because they're radioresistant. So they got lots of FMISO scans of colorectal cancers, and the problem is twofold. It's a bit unlucky. First of all, the rectal tumours are not all that hypoxic, and secondly, the rectal content seems to take up the tracer a lot more than the tumour, so you couldn't actually properly see what was going on. So, and that's not specific to the Oxford study. There was another study somewhere in Europe that had found the same thing. So that might be a good area for using MR instead. I don't know, but it's strange how these technical issues kind of have different effects at different treatment sites.
Sure. Dale follows up and says that whilst thanking you, he's also pointing out that there's been observed improvement in outcome in rectal cancer patients who are taking metformin. Of interest.
No, okay.
So, any more questions? John, that was really, really useful and good, and takes us into an area that we don't often think about. So thank you so much for your time. Thanks to everyone else for dialing in.